moderate the questions and answers as a co-host.
اوكي.
خلاص.
الحاجة الثانية يعني احنا في النص ممكن
انا عمري يعني انت ايه بالنسبه لي وانا
today. We're so happy to be with him. All of the speakers, يعني الدكتور محمد حسني وانا we are يعني participants in Baladi Foundation, which serves great deal of patients, particularly glaucoma patients, but also cataract patients and the patients who need oculoplastic surgery in Aswan. This is a great foundation that is funded by the efforts of all ophthalmologists who care about our people in South. Eye Care Center now is established 10 years by now. It's founded in Maadi, and it's very up-to-date daycare center that is offers all services related to ophthalmology. And it's this is a 85 years old villa renovated. To be able to provide a good, simple, up-to-date service to the patients in a nice atmosphere. So it's 10 years now. Now you can have the first sip of tea, and we should go on. I'm going to speak. It's not a lecture, but I'm going to speak about difficulties that we can see as cataract surgeons or anterior segment surgeons. One of them is shallow anterior chamber. If you face a patient, whether he's having angle closure glaucoma, acute angle closure glaucoma associated with cataract, or chronic angle closure glaucoma with cataract, or only very shallow anterior chamber like this one or this patient. So you really have to consider a lot of things that helps you to make this surgery efficient and safe in the same time. But let's have another sip of tea and have a look about, was it thousands of years ago,
and the same sweeping movements with the
they had in their surgery technique like couching like this, was it a problem to have a shallow anterior chamber? Was it an issue to have an anterior chamber that is shallow to defy the good visual results that the patient can have? So if we move forward, fast forward in the 50s, this is the first surgery done by Harold Ridley, doing cataract surgery and removing and implanting the first intraocular lens. This is Griffey knife, the large incision. But again, I'm showing this to show where have we developed, and as we develop, we start to face problems and difficulties that we didn't have before. So I don't think at that time he would think, is it the anterior chamber shallow or not? Because the technique does not have a differentiation between if you have a shallow anterior chamber or not a shallow anterior chamber. So let's move to the present era. Since we started phacoemulsification, then it became an issue because you have a lot of steps, a lot of details that you need to take care of so as to have safe surgery. So let me go through this first video. This is a patient, young patient that had very shallow anterior chamber, previous trabeculectomy, and peripheral anterior synechia all around. You can see how shallow is the anterior chamber. By time we should learn what to do. Sometimes you have this appearance in intumescent cataract. So sometimes we need to decompress or give a space for the anterior chamber to be inflated by doing vitrectomy through the pars plana. Otherwise, like in this case, the most difficult step essentially is the capsulorhexis. You have to be very careful. You have to stop and inject viscoelastic all the time to make sure that you get a continuous capsulorhexis. And also you'll find all the time the iris is prolapsing if there is positive pressure. And usually these patients, if they have short axial length, they have high pressure. So my recommendation in such cases, usually it's better not to do it under local anesthesia, to do it under general anesthesia, and to be extremely careful and to be as well concerned of the possibility of intraoperative complications, one of them suprachoroidal effusion. Repositing the iris at the end of the surgery from a separate paracentesis is the best way to deal with a prolapsed other iris in such cases. So this is one difficulty. Once one works different cases and finds different difficulties in such cases with shallow anterior chamber or with glaucoma, so with the development of technology, I was opposing the use of femto laser, and I didn't think femto laser was of value for us. But for this patient, he was 56 years old male who had chronic angle closure glaucoma on treatment, never done surgery, multiple iridotomies that most of it healed, and all the angle is almost occluded with synechia. So I decided, and very shallow anterior chamber, almost less than 2 millimeters. So I decided to remove one of the main difficulties in such cases is doing a perfect capsulorhexis without the hassle of working inside this eye with the regular capsulorhexis or even micro forceps, and as well doing perfect incisions. So let us go through this. You see the perfect rhexis, incisions already opened, which would prevent the iris prolapse. And now I'm trying, maybe Dr. Tariq Sharawi can interrupt during this to show, is it a useful way to dissect with viscoelastic and with the cannula peripheral synechia during surgery or not?
I totally agree that synechulisis is useful during the operation. I use also viscoelastics, and I use blunt vitreous spatula. You can librate the angle. I totally believe in that, but that does not usually reflect on pressure reduction, because even if you librate the angle, the trabeculum has already been damaged. So I doubt that synechulisis is morphologically very appealing, but I don't think it actually reduces intraocular pressure.
So do you think we should do, this is true, for this patient, it didn't reduce the intraocular pressure. But when do you think synechulisis is useful? Is it related to the duration of the surgery, the synechia?
It's almost always related to the duration of how long ago had the synechia happen or form, and how extensive it is. I mean, I wouldn't think that more than 180 degrees of synechia would, even if you librate them after a couple of months, there's probably no chance of regaining pressure. Mainly, I use viscoelastics to actually break synechia between the iris and the anterior capsule because to dilate the pupil. That is my main reason to break synechiae. Peripheral anterior synechiae, yeah, you can break them, but I don't think it's, to be very honest, it makes no difference. And if it is more than 180 degrees of synechiae, then you are better off adding something to the operation, probably a trabeculectomy with the phaco.
Okay, yeah, and you don't recommend to do this, synecholysis?
I don't think it has any real repercussion on surgical success in terms of pressure reduction. So you can always do it, but in some cases, you can actually cause ciliocoroidal detachment, and you might end up in a hypotony. So if you do it, you have to be very careful. And in many cases, if you do it aggressively, it can also bleed, which makes the operation more difficult.
This is important note. You have to be careful because sometimes you injure the root of the iris or insert the root of the iris, and this can cause annoying bleeding. One of the things also you have to be careful in long-term glaucoma patients and shallow anterior chamber, that you have to protect the endothelium. By experience, one knows that these endothelia, even if they have good count, they are not very healthy. They are easily affected by the turbulence, by ultrasound. So you should actually use almost the minimal possible ultrasound and to work the furthest away point from the cornea. Because one of the main complications, post-operative complications in glaucoma patients with cataract is corneal decompensation. Dr. Mohammed Hosni, would you agree, Dr. Mustafa?
مساء الفل عليكم كلكم. Yes, I totally agree. I just have a few comments على اللي حضرتك you just said, Dr. Yahya. Number one, I agree with Dr. Tara, of course, that يعني doing a sort of a synecholysis during cataract surgery will not decrease the intraocular pressure post-operatively and might lead to hemorrhages, as you said, برضو, Dr. Yahya. The thing is, if I decide to do, if there was like a big chunk of synechia that I would like to liberate the angle at that point, I would definitely do it later on during the surgery, and I would not do it before finishing my phaco, for the simple reason, and while we are doing this synecholysis, the people might come down, and this can happen very, very easily. These patients with shallow ACs, and if you have intumescence as well, I've had patients like this يعني very frequently. ما أعرفش ليه يعني always my patients, some of these patients come to me. Because the thing is, if you try to do anything at the iris, even if the iris prolapses and you put it back inside the eye, sometimes this sort of stimulates the pupil to come down, and your life becomes a little bit miserable for the next few minutes.
Everything has an advantage and disadvantage, يعني rationale, but doing at the end, the bad thing about doing it at the end, already the anterior chamber have deepened, the iris is not supported well, so it's loose, so the tendency to bleed is more. And if you do this after implanting the intraocular lens, and if there is bleeding, it will go behind the lens, and then it's more difficult. If you are at the beginning, you deepen the periphery of the anterior chamber, and if there is bleeding, you can just raise the pressure and tamponade until this bleeding stops. So,
Dr. Yahya, I have a small. There is no right and wrong in these situations.
Exactly.
I totally agree. Yani, you do have a point, but the thing is, if you have the lens out and the iris, the peripheral iris, is sort of bowing backwards, I think this will give you like a second hand, and it's actually assisting you to do just very, very
it's going back without tension. Yeah, it is more pliable. But anyway, yeah, what we want to convey is that everything here, I'm trying to pull the iris, pull the angle. Tariq, yeah, it will be appropriate here to ask you about Ammar Agrawal have published last year, or I think last year in Journal of Cataract and Refractive Surgery, about his technique of 4 throws, 1 suture, pinpoint pupil, as a method of treatment of angle closure glaucoma in such cases. Here is the bleeding, Muhammad, at the end.
Yeah.
I'm aware of that, and I know that a lot of anti-segment surgeons are trying that, but I'm very skeptical about this. I'm not.
Because it's opposite the idea of what you were saying. It's
Yeah,
complete.
I'm fully convinced that I mean, if you are an old hand at the glaucoma business, you know that once the trabeculum is done with, morphologically improving how it looks doesn't improve its functionality. So going into this extensive surgery, throwing, multiple throws on the pupil to retract the iris away from its root seems to me like a fancy maneuver with very little return coming back from it.
I mean, his results, he says it's very good. I talked to him personally, and he's very happy. But of course, he will praise it. Yeah.
It's a cohort. It was not a randomized controlled trial, and cohorts provide very little information when you are doing something like that. I struggle to understand that the mechanism that would be responsible for reducing pressure by just revealing the trabeculum that has been damaged for sometimes a couple of decades. So and in addition to that, working with in the antechamber for a long while by prolonging the operation, even if you're doing it with phaco, the endothelial cell loss that will be significantly more than regular phaco. I do not see that the ends would meet. I mean, the end results for me are not. How can I say that? I'm struggling to be diplomatic. I think it's bullshit.
Okay, هنشطبها دي.
لا, I think if syneculitis is damaging one portion, doing this type of surgery will be damaging to the anterior segment 10 more times. You will end up with a lot of flare, a lot of cells post-operatively.
I think Muhammad, what Tariq said is, this is a cohort, but if you do a randomized,
you cannot do an RCT for these patients. You cannot match them correctly. You cannot have the proper sample size. I don't think an RCT in this for this technique is doable. What do you think, Tariq?
Sample size has to be humongous, and it takes into consideration demographics, and the demographics will be very complicated in terms of balancing.
And to get a big size of patients.
You already had studies talking about the clear lens extraction in angle closure glaucoma, and this.
But the Eagle study, the Eagle study was multi-centric, huge study, and there was a strong scientific, conventional wisdom behind it, and nobody before it actually knew what the results were, and the results at the end were not light and day. It was not, black and white. So even with the Eagle study, the conclusions that your take from the Eagle study can be different, significantly different from where you stand. So I wouldn't join an RCT looking at pulling the pupil and disfiguring it in favor of further disfigurement of the angle, hoping that this would reduce the pressure.
Okay. Plus the fact that recruitment in the Eagle study was easy, to have glaucomatous patients with shallow ACs, but to find a large number of patients with exactly the same matching synechiae, I think this is very, very difficult.
And lens size, and antechamber depth, and gender, and the form of the iris and the thickness of the iris. It's the variables are so many that coming out with something, I don't know. It's a fancy surgery. It looks very sexy, but you and I, we all four know that we have been in this business for some longer time than what we would like to remember, and we have seen a lot of fashions come and go.
Exactly. So just the take-home message about difficulties in shallow anterior chambers or patients of angle closure glaucoma, there are things related to the technique of surgery. One of the difficulties is the capsulorhexis, iris prolapse or high pressure, and the possibility in short axial lens to have choroidal detachments or suprachoroidal hemorrhage in older age. So these things we have to be aware of, and it's not the syneculitis is not a proven thing that will improve the intraocular pressure postoperatively. So if the patient is not controlled, maybe we can do either surgery like trabeculectomy with it, or now other surgeons, they will do trabeculotomy, or they pass the GAT technique, if Tarek agrees with what I collectively. And be careful for the corneal endothelium in such cases. Now I will move rapidly into another situation that will tell you that even with a lot of experience, a lot of knowledge of different cases, you have always space to learn, a space that you see new things. This is an old patient that was a mother of a doctor, straightforward case, vision best corrected was 20/70, intraocular pressure 20 without medications, normal funded, nothing alarming. And I thought this is a straightforward case, but sometimes your days are not the best. One of the days is not the best. I punctured the anterior capsule, no problem. But here, I notice as I work with high magnification, normally this is my normal magnification, so I can see that there is something abnormal with the zonules. I can see that the zonules are inserted too central. Again, I thought my difficulty will be to perform a continuous rhexis without extending through these anteriorly inserted zonules to the periphery. And you can observe that the zonules are very long and inserted very central, leaving only about 4 or less millimeters of clear anterior capsule. And it is all over. It is not in one area that you can easily avoid. It's all over. But I managed to do a complete rhexis, going slowly. But here, have a look. Although I did complete rhexis, I will see and make more magnification now to see what's happening. You can see the zonules are stripping out of the insertion in the capsule, and this happened all over, but I didn't realize how significant that is, although I got a continuous rhexis. So I said, I passed the difficult part of the surgery. I'm doing my regular chopping technique, vertical chopping. Nothing alarming for me now. Now, I started to see that the whole bag is wobbling. So I immediately thought probably there will be zonulitis. I did not imagine how big the zonulitis is. I started to ask to have a capsule tension ring ready, a 3-piece lens ready. And now I'm trying not to go with the fake one at this point, trying to identify what's the problem, releasing the remaining nucleus of the bag. And you can see now at the edge, the whole area, there is zonulitis. Again, I said, no problem. I will have the capsule tension ring, maybe sutured capsule tension ring, no problem. I'm trying to express by inflating the bag, pressurizing it, and then trying to get some of this epinucleus out. And again, evaluating the bag. Still, the whole bag is intact. I have a continuous capsular rhexis. So it was a mistake thinking that I could aspirate this. And now it's very obvious that the whole bag has zonulitis. I did not induce it now. It's all, there is complete zonulitis. The whole bag is stripped of the zonules. Now I'm stuck with the situation that the bag, now you started to get tense because you're getting unexpected problems. My whole concern now is to get rid of what is remaining of the nucleus and the cataract without going into the vitreous. And up till this moment, I did not have vitreous loss. Still, the anterior vitreous face is intact. So again, you can take a deep breath and think, what can you do? The best option, retrograde here, I would use a sutured capsule tension segments, not ring. and capsular hooks before I do this to hang this remaining subluxate or dislocated whole bag. Putting capsule tension ring, capsule hooks would hold it for me until I remove the contents. Then capsule tension ring segment sutured. This would be the ideal scenario if I revisit the case, and maybe I would put it earlier on. Now all my attention is focused to get rid of the remaining nucleus and epinucleus, cortical material. Still thinking I can preserve the bag. I'm checking if there is vitreous. You can see now there is a strip of vitreous coming out. So already I took the decision. I'm going to remove the whole bag. And I will now the anterior vitreous is disturbed. So I should do anterior vitrectomy with high cutting rate, low vacuum, and checking again for vitreous. Now the options, what are the options for the lens? I wanted to constrict the pupil, but because it is not the best day, I got hemorrhage from the angle through injuring the root of the iris and bleeding. But I'm thinking at that time, what are the options for IOL implantations? And because I don't have the best luck at that day, I thought I will use a very sized lens. Of course, you can have the options of anterior chamber lens, but definitely you have to have a constricted, much better constricted pupil, or you can have put a scleral fixation lens or through Yemeni technique or through sutures, but I didn't want to go through this. Now, after stopping or decreasing the bleeding, I pulled on the iris to constrict it, and now I'm putting the iris claw posterior enclavation. You can see the area why the bleeding happened because of peripheral iridodialysis. I found out my position mechanically was not easy to hold and enclavate the lens. So I enlarged the paracentesis, rehold the lens, introduced the forceps from this enlarged paracentesis, and then enclavating the lens. To add, for the bad day, it is badly enclavated. I had, in this situation, to disenclavate the lens because you have to finish your work, even it takes longer time and it's not your best day. So I just de-enclaved the lens and using extra paracentesis to help me to manipulate the lens and enclavate the haptic that was misplaced. And then I thought this is the end, the case ended not perfectly, but as best as possible for such a case. Post-operatively, the patient, the vitreous hemorrhage cleared in 10 days, but the intraocular pressure, which was interesting, was not controlled by all means of medications. And she had to do a filtering surgery. When I researched the literature, I found the condition called long anterior zonule syndrome. And this could be partial or complete, like my case, which is less common. And there have been genetic studies that was done to see a correlation between these patients of long anterior zonules and glaucoma, a type of open angle glaucoma. And there is many theories to explain why these patients get intractable glaucoma post-operatively, and even without surgery, they can get glaucoma. So you should watch, and I learned from this case, I should always look for the anterior zonules insertion more than I used to do, even pre-operatively. And we definitely now say this is partial long zonules, this is total long zonules, and we are much more careful about such a rare condition that tells you that you always will learn so long you work and live. So thank you for your attention. And we move for Dr. Tariq Sharawi.
Thank you, Yahya. I will if you allow me, I will share my screen. Can you
Can you comment on the longs and mules?
to be honest, it's the first time that I hear about this syndrome. It seems to be that it is absolutely rare, and I see the difficulty. I understand the bad surprise, but as you say, I mean, we live to learn and operate another day. So brilliant surgery, and at the end of the day, you handled it well. I will
share screen.
Yeah, I'll share my screen. Let's see here. Okay. I presume you can see my screen now.
There you are.
Good. Okay. So I come here to share in this nice meeting with close friends. I think the four of us, somehow we managed to grow up together throughout the last many years. We're not going to mention figures. And I thought I will come and tell you a story. It's a story about something that happened more than a century ago in Basel. And as you can see from the tones of this presentation, and because I know that Muhammad, Mustafa, and Yahya will be seriously, giving you some absolutely high quality information, I decided to actually basically half a harrag and half to speak about something that I think is very interesting, and it has a big passion for me in my practice over the many last years. So it all started in Freiburg, in the University of Freiburg in Germany, where this gentleman, who is Theodor Axenfeld, was a very big name in the field of ophthalmology, a big doyen. And because of that, he attracted, clever minds from all over the world. And one person who decided to join him was this guy, whose name was John Gustav Lindberg. Lindberg was a Finnish guy from Helsinki. And when he was looking at eyes, he observed some sort of he had a very good eyesight, and without any really big magnification, he could see some whitish matter on the pupillary margin. And he mentioned the story to Axenfeld. He mentioned what he saw to Axenfeld. To the credit of Axenfeld, he actually sponsored Lindberg to go and meet another guy in Stockholm, Alvar Gullstrand. And Gullstrand, most of you would know, is the only ophthalmologist to ever win a Nobel Prize in medicine. And that was mainly based on work that he did not do in ophthalmology. But among the things that he has done in ophthalmology was to create a prototype for one of the very earliest slit lamps. As you can see here, this is the original drawing of Gullstrand's slit lamp. And he has been, he has been very cooperative with all of his colleagues, that when Lindberg went to see him, he took the blueprints of the slit lamp and he reconstructed a new slit lamp in Axenfeld laboratory to look at eyes. And after finishing, he took it with him to Helsinki, and there he actually discovered and published in 1917 his doctorate thesis on what we now know as an exfoliation syndrome. Now, it doesn't stop here, because something fishy happened in 1920. In 1920, Karl Vogt, the very famous Swiss ophthalmologist, who was at that time working as the chief in the University Hospital in Basel, actually organized a big meeting, and Lindberg went to attend. And it was thought that in 1917, after he published his work and meeting Vogt in 1920, there has been rumors that that actually Lindberg brought a copy of his dissertation to Vogt, who published from 1923 to 1926 3 well-known papers on exfoliation syndrome, and was credited to be the father of the discovery of exfoliation syndrome. The work of Lindberg was never mentioned. There was a paper that came out in Acta Ophthalmologica by two of my very good friends, Ati Tarkanen and Tero Kevalla, both from Helsinki, that actually accused Lindbergh or accused Vogt of stealing the work of Lindbergh. And I was approached immediately after the publication of that, because at that time I was still working in Basel, Switzerland, and I was asked to find out if what they claim has any merit. So I spent weeks looking into the archives of the University of Basel, only to find that in 1920, a copy of the thesis of Lindbergh was actually dedicated to Vogt and given to him. So it is almost impossible to believe that Vogt did not look even at the cover of the paper, of the cover of the thesis. And that will bring us to a very interesting conclusion at the end. But let's speak a little bit about exfoliation syndrome. It's the most commonly identifiable cause of glaucoma. So among all types of glaucoma, this is the most common identifiable cause. And it accounts for more than half of the all open angle. Obviously, it's the secondary open angle glaucoma in many different places and different populations. And you can go from Scandinavian countries to Ethiopia, to Saudi Arabia, to Greece. Not very easy to understand the link between those countries. And even if you look at the world population, the only population in the whole world where exfoliation was never seen were the Alaskan Inuits. In Iceland, about 40% of the population have pseudo-exfoliation syndrome. In the US, 40% of the Navajo Native Americans have the syndrome, while among African Americans, it's 0.4%, so very, very little. And again, in Africa, the continent, West Africa, as in Ghana, has very small percentage of pseudo-exfoliation syndrome, while South African blacks have about 8% among them. And even if you look at the United States of America, people living in the northern tier of America have 114% increase in the risk, while if you live in the south, it produces a reduced risk of about 17%. So if you look at the American figures, what comes clearly to mind is that it happens more, or exfoliation happens more in places with lower temperature, sunnier weather, higher altitudes. And it is obviously associated in a good percentage of cases with an exfoliation glaucoma, which is it has a very serious clinical course, as you know. It's extremely rapid in progression. It has poor response to medications. And in many cases, you have to resort to surgery. Now, remember that the early manifest glaucoma trial found that the morbidity related to exfoliation is significantly more than primary open-angle glaucoma. So if you are going to treat pseudo exfoliation, you have to be extremely sensitive and really serious about reducing the pressure and reducing it fast, because in many cases, patients would develop blinding disease of glaucoma. Now, this cartoon reminds me of sometimes doctors not actually looking at the obvious. If you look at a patient and it doesn't jump in your eyes that the disease is there, then there's something that is going wrong. And that reminds me of our beautiful Shadia, when she always said, when she sang, "Dawar alayh til'ah, dawar alayh, dawar." So if you actually look closely at the iris and work with a small slit beam of light and focus on the iris, on the iris margin, the pupillary margin, you can identify the central disc of exfoliation, which is surrounded by an area or a ring of clear anterior capsule. So you can see that in another video that basically shows that you're the same thing. So even before dilating the eye, you can always capture those cases. Pupillary margin in those cases have whitish exfoliation matter, and you can find transillumination around the pupil happening more because of the friction between the posterior margin of the pupil with the anterior lens capsule. In some cases, you can identify the position of pigmentation that is coming out from the posterior iris surface and creating a Krukenberg spindle-like phenomena. Most of those cases are associated with dryness, and you can identify easily dry corneas. So remember that most of those patients suffer from an ocular surface disease and dry eyes. The angle is obviously associated with this gentleman, a very good friend of Egypt and of ours. This is a meeting that we organized in Aswan in 2001, and that is, of course, the famous Sampaolesi. And the Sampaolesi lines are notoriously well known and important to find, especially in pseudophakic cases where you cannot find the classical configuration on the anterior capsule. Remember that cases of pseudoexfoliation are associated with very high fluctuations of pressure, usually in the range of 15 to 20 millimeters if you do a 24-hour diurnal curve for your patients. Now, when we come to speak about medical therapy, a lot of people used to give myotics. I'm not a big fan of myotics because there are lots of issues related to complications related to myotics, but they do work. Aqueous suppressants, by decreasing outflow, some studies have theorized that it can be harmful because you are not washing out the exfoliation material that is coming out. Phacos can reduce the pressure, but don't expect a fantastic drop of pressure. Here I'm using Grishaber iris retractors, and I'm hooking the anterior capsule before going in with my phaco device. Now, remember that when you see pseudoexfoliation, you should consider doing the phaco early, because operating early reduces the risk of complications that are well associated with problems of pseudoexfoliation. Argon laser trabeculoplasty does work, but you have to reduce the energy, or SLT also, but you have to reduce the energy for the fear of burning the angle, knowing that the angle is absolutely pigmented. And usually it doesn't work for a long while. My favorite procedure for pseudoexfoliation glaucoma has to be deep sclerectomies. Why? Because in deep sclerectomy, as you can see here, we are peeling the inner wall of Schlemm's canal and the juxtacanalicular trabeculum, and this is exactly where the maximum resistance to outflow happens in a case of primary or secondary open-angle glaucoma. And to be honest, those cases are relatively easier to do in pseudoexfoliation because you can see the pigmented trabeculum in a much better way than in primary open-angle glaucoma, where the trabeculum sometimes is absolutely transparent. So what is left is what we call the trabeculodesmate membrane, and this is again a case of pseudoexfoliation glaucoma, and you can see the aqueous coming out through the trabeculodesmate membrane. The antechamber depth is well maintained, and you don't have any related complications, or they happen, let's say, rarely in those cases. As you can see here, this is the dissection after a deep sclerectomy with an intrascleral space having been formed and a trabeculodesmate membrane that you can later perforate or puncture with a YAG. This is a Hagstride CGA-L1 gonio lens. That is my favorite device, my favorite lens to do a laser gonioscopy. And you can see in a case like that, where the patient's pressure is going slowly up, we go with the laser and create small holes in the trabeculodesmate membrane that we call goniopuncture to try to bring the pressure down. And this is a UBM study. Actually, it's an anti-segment OCT study. And you can see this is a series of patients that have been published by my fellow Jolt Varga maybe 7 years ago. This is a case where you can see the intrascleral space is almost totally obliterated. That's 4 years post-operatively. We do the goniopuncture, and immediately you have a reformation of the intrascleral space and drop of pressure, and a reformation of subconjunctival filtration. And this is 3 months after the goniopuncture. Pressure is still well maintained. Goniopuncture happened. Goniopuncture led to an increase in intrascleral space and a good amount of subconjunctival filtration. We have experimented with the pressor flow, an implant that you can put subconjunctively, as you can see here. And the results, I have to say, have been quite promising. I'm a bit reluctant to share long-term results, mainly because I don't have them. The longest follow-up that we have for those cases are 5 years, and the results are good enough. And they give you also some sort of a bleb that is far away from the limbus, because the filtration is happening at 11 millimeter away from the limbus. The blebs associated with that are actually quite diffuse and are away from the limbus, so they give you this hybrid bleb. You can also do something very similar through the Zen implant by injecting ab internal the implant to go into the subconjunctival space. More or less, I am reducing the number of Zens that I'm doing now and doing more of a pressor flow, which is an ab external approach. Maybe the only niche that is left is combined procedures, where at the end of the operation after a phaco, you can throw one of these. The results are relatively good, and the operation, as you can see, it took maybe a minute. So this is all that we have in terms of glaucoma surgery now. Every single one of those is either FDA or is CE marked. And it might make sense to you that probably enhancing Schlemm's canal pathway by puncturing somehow in one way or another the trabeculum via an eye stent or via hydrus, for example. As you can see here, this is the first generation eye stent being bypassing the whole trabeculum in a pseudo-exfoliative case. Some cases do well, very well, but my long-term results with the eye stent have not been what I have hoped for, knowing that I'm working, I'm actually consulted on cases that are relatively advanced and of long-term damage. This is the hydrus implant, which should do better than the eye stent because it is a titanium plate that takes a whole segment of the Schlemm's canal, potentially is an interesting tool compared to the eye stent. There's no randomized control trial going head-to-head against between the eye stent and the hydrus, so the jury is still out. Now, to end up my story, you know, even something that happened exactly 100 years ago. So in 1920, when Carl Alfred Vogt and John Lindbergh met, whenever you try to bury a skeleton, the skeleton is always there, and in many cases it's almost always found. So honesty is not just a good trait, it's also the intelligent choice that you should make. I have to say that to honor Lindbergh, a few glaucoma specialists about 15 years ago decided to create the Lindbergh Society, which is a society focusing on exfoliation glaucoma, headed at this point of time by my good friend Bob Rich. And so one name goes on into history, and another is sooner or later going to be forgotten. Here are my contact information, and if you absolutely want to contact me by phone, you can also find my contacts here with my email. With that, I thank you very much, and I hope that you found this talk interesting enough. Thank you.
Thank you. Thank you, Tariq. Very interesting. I have two questions and a comment. First question, when you showed your flow chart of the so many ways to treat glaucoma, maybe I missed it, but you are talking always about this in instrumentations, but you didn't talk about GAT, which in our society, in our economic level of patients, it doesn't cause any, it's very inexpensive. And what's your feeling about it? Why you don't talk about it? We have Dr. Yasmin Said, she works with me in the department. And of course, you know her, and she does a lot of this, and it seems she's very enthusiastic about it. I want your feedback.
Yeah, I'll tell you my 2 cents regarding this. GAT is a very clever operation, and it can work wonders if you select well your patients, because it needs patients that are not too elderly, patients where the Schlemm's canal has not collapsed for many decades, it needs a very well open angle, but above all else, it needs a very good surgeon. I have worked with deep sclerectomy for, I guess, for about 25, 30 years now, 25 years, I guess. And at that time, deep sclerectomy was a very demanding operation, and I struggled to promote the operation on a global scale because the skill set to do a deep sclerectomy is a bit different than to do something like a trabeculectomy. At least that's my opinion. Now you take glaucoma surgery, which is a domain now that does not provide training for hundreds of surgeons, and on many cases we do not do that anymore. And you try to introduce an operation that is even more complicated than everything that we almost ever had. I think that this is a niche operation that will remain in the hands of some fantastic surgeons like Yasmin. Having said so, I am in the business of teaching glaucoma surgery to as many people as possible. So my hope is that we can offer something that the majority of ophthalmic surgeons can master. Remember that as time goes by and as the demographics change, and as we do not have any new pharmacological molecule that can really, neuroprotect the optic nerve or whatever, we still have to rely on surgery. So surgery has to become more and more a tool for us to use. And if you're talking about GAT, I lift my chapeau for you. Of course, GAT is fantastic, but how many surgeons can we train enough to answer the problem of or the load of glaucoma patients in Egypt? I think if I have to advocate in Egypt trabeculectomy or GAT, I would still advocate trabeculectomy. It is a cheaper procedure. It's easier to learn. If you master it, you get excellent results. So I have loads of respect for Yasmin and for other clever surgeons, but I don't think this is a solution that can be generalized.
I partially agree with you, because anything can be taught if you give time. For example, Yasmin has taught a younger colleague in our department. She's a very good surgeon, Dr. Mona Ahmed, and she is a very good surgeon, and she's doing. So I mean, even with the fancy, I have attended the course, the excellent course you make for the mix, the first one actually, and I learned a lot. But still, you need some skill. You need to know how to do gonioscopy. So anything have to be taught. I agree with you. It is maybe, I'm not promoting the surgery. I'm saying it's an option that is present if you have selective, like the difficult refractive cases goes in Egypt to Mohammed Hosni, for example. We don't see them. These certain glaucoma surgeons, you can train 4 surgeons, 5 surgeons. Why not? On all types. Because
you certainly can. You certainly can. The question is, how many surgeons do you actually need? I mean, if we're talking about single-digit numbers of surgeons, I'm sure that 100 million population or a few billion around the planet. I mean, for example, would you actually go and teach trabeculectomy in Congo, or would you teach GAT? The answer is extremely clear for me.
Yes, I agree. But now you are talking about, we are not talking about GAT or trabeculectomy. We're talking about GAT or very, very, very expensive next surgery.
I agree. I totally agree. But I'm not also promoting the very, very, very expensive MIGS surgery. I still use deep sclerectomy as my main operation that I practice anywhere around the world. We need to look and learn, but I am very keen on simplifying glaucoma surgery. I think we need something in glaucoma as good as phaco or as good as LASIK, and my gut feeling is that GAT is not the holy grail. I do practice GAT. I do it in selected cases, but you know, when some people would listen to you, you have a responsibility also to advise or to guide in a direction that is attainable, that is pragmatic.
Yes, but definitely, it's very obvious that you clarify that if most of the people will learn trabeculectomy or deep sclerectomy, but if we're talking about options, just to let people know the difference. Yeah, there are different things in the big chart you showed. So I'm
That is in the chart. That is in the chart. I mean,
okay,
it is not ignored. It is mentioned, but I don't focus on that.
Okay. The second question is, you talked about perfectly well about pseudo exfoliation. What about true exfoliation? What is true exfoliation?
True exfoliation is a matter of history. Most people now use the word exfoliation rather than pseudo exfoliation because the true exfoliation has been the glass blowers in Venice like a zillion years ago, which we don't really see now. So I've never seen.
I have seen.
You've seen, good.
I've seen like 3 cases.
And where they were glass blowers as well?
No.
And what were they doing to have true exfoliation?
They were normal people, yani.
So how did you know that they were true and not pseudo exfoliation?
Because two things, clinically and in surgery, you will find the whole membrane over the anterior capsule plus what you see in pseudo exfoliation. It's very interesting. Actually, one case was in the case presentation section in a Journal of Cataract of Refractive Surgery, and I commented on it. And this was many years ago, like 10 years ago or something. So it's just to tell people that there is the exfoliation. It's very, very, very rare.
Yeah, so it is safe to say that if you see exfoliation on the lens, it's probably a pseudo exfoliation syndrome rather than the true exfoliation.
Yes, exactly, safe. And the message with the cataract and pseudo exfoliation, the association with glaucoma is you have perfectly clarified, but in the cataract part, people should notice few things. They might be subluxated or they will develop subluxation. So it's better to do, and they have a high tendency for capsular phimosis, and capsular phimosis helps in the whole capsular bag dislocation. And now we are in the era that we see a lot of these patients coming 20 years after surgery with the whole capsular bag dislocation. So we don't have too much clues to prevent this, but one of them is large capsular access, putting a capsule tension ring and using a 3-piece lens in these cases. And of course, to care for the glaucoma. Thank you, Tariq, very much.
I'll tell you one anecdotal, it's also research. We looked at pseudo exfoliation syndrome complications among English surgeons or UK-based surgeons compared to Swiss and German surgeons. And we found that the complication rates in the UK is significantly higher. And I can tell you actually why. Because we do not offer surgical training for our fellows and residents. So all these difficult cases are done by experienced surgeons who know how to operate pseudo exfoliation. Now, in the UK, most of those cases for the fellows and residents to operate, they try to push away because they don't want to increase their complication rates. So they end up being operated at a very advanced stage when the complication rates are higher, even in the hands of good surgeons. So my take on that is when you have a pseudo exfoliation with cataract, operate early rather than late.
Okay, thank you, Tariq. I think we should move now to Dr. Mohammed Hosni.
Thank you, Dr. Yahya. Tariq, I have to say, your presentation, come back, put the video back on. Your presentation was very, very nice. It was really nice, honestly. And one of the things, let me just elaborate on this. One of the very, very true things in medical education is the philosophy of education. I think we all are very good surgeons. I think the number of good surgeons is increasing by the day exponentially. But the thing is, to have a message in teaching, this is something very important. And the way that you answered the question of Dr. Yahya Salah on the GAT was really, really admirable. So thank you so much. The thing that I would like to comment on is Having seen the small snips of videos that you just saw, that you just showed us, there was this new tube that that does the bleb 11 millimeters away from the limbus.
Pressure
It
flow.
gives a hybrid lead. What's it called?
Pressure flow.
The pressure flow. This is the first time for me to hear about it. I'm actually interested in MIGS, but I've never heard about the pressure flow. So this looks like a pretty interesting device. Is there any way that this can be economically produced by a sort of a, not a local, but a low budget company like in India or China or something like this? This would introduce the world of MIGS and into the countries like ours, and become accessible to the so-called average surgeon. What do you think? What's your take on this?
So I am very interested in the pressure flow, mainly because it's a very easy way to do it. And as you know, and you are very good in physics, Muhammad, it all relies on quasi-low. So the length, the viscosity, the diameter, it works well. I never had hypotenuse with those. And what I am, aside from this idea of a hybrid plate, what I find very interesting is that even if you lose control of intraocular pressure 3 or 4 years down the line, you open, you clear the scarring, you put mitomycin, and you basically close again, and it gives us another life. Now, I know that we are speaking just the four of us and nobody is listening, so I am free to say that this is something that is easily copyable. The original device is the pressure flow, was done by one company and then bought by Santen, which is a Japanese, of course, a mega company, as you know.
Yeah.
It is made of a material called SIBS, and SIBS is a material mainly used for cardiac catheters, so for cardiac catheterization. But the principle is really simple, and it is absolutely doable. But there's always also a way of gaining access of something like that into a market like ours, which is bulk buys or negotiating something that is really associated with our market. And a good example is Ahmed Valve by the New World Medical, which is sold by 10 times more expensive in Switzerland than compared to Egypt. So it is business of glaucoma has to rely on good businessmen. And good ophthalmologists can be good businessmen, but not all ophthalmologists are good businessmen. So to negotiate well with companies, something is a talent. I'm sure that we in Egypt, we have among us, if we actually work together, we can really negotiate a good deal for our country. We have strength in numbers. In a population, a market of 100 million.
Can I just elaborate on what I was saying, because I was going somewhere, and we will meet in 2 seconds. Yeah, the thing is, we do have this in the Boston K Pro. We have the good old Boston K Pro, and we have the one which is done mainly for research purposes, and which is very cheap, and you can use it in third world countries like ourselves. The thing is, it is not every day that we have someone on each and every board or advisory board of glaucoma products in the world like yourself. So my question is, it's a very direct and a very, very clear question. It's very, very nice. It's very good. It's really good. And you come around and teach people, and you do the fancy surgeries and very updated surgeries. You teach a lot of ophthalmologists about the recent trends in glaucoma in general. But the thing is it possible to negotiate a cheaper version of one of the easy procedure MIGS, especially for our part of the world? Is this doable? I know it's a mega business, and Santen, can they produce another version that's in a cheaper packaging for us?
No.
Is this doable?
Yeah. You need a straight answer, and the straight answer is yes. It is absolutely doable, and I know how to do it. And I'll just need some backing, because if I am not going to buy for Egypt, but if we have a group of surgeons, of key surgeons that will be interested, of course it's doable. everything is negotiable in life. We can negotiate prices for Swiss watches, so we can negotiate for an implant like that. I am very optimistic that this is absolutely something that we can achieve.
Thank you. Okay, so it's my turn now, I think, right? And again, I'm presenting from the iPad, and I will go into the dilemma of sharing my screen again. I'm not pretty sure that I will be successful or not. Okay. Am I on now? Hello?
You are on.
You are, so you can actually see my screen with the
Yes.
first slide, right?
Yes, make it full. Yes, perfect.
Okay. So good evening, everyone. I hope you are enjoying this meeting. It was supposed to be an informal sort of friendly chat between friends. But it became extremely scientific when Dr. Yahya and Dr. Tariq gave us their presentations. Tariq's presentation was very, very interesting for me. I love history, and I'm going back to see if Vogt really had anything to do with Harada syndrome, and or did he steal it from Koyanagi Harada? And I would like to see who else discovered the Vogt stria and he stole it from them. So I really hate the guy now. So thank you, Tariq, for giving us this insight. And I will start my presentation. So my presentation is, and I will take you guys on a different gear. And it's an informal, friendly chat about what I think about glaucoma medications in general, especially in our cornea business, and especially around corneal transplants, because we do crossroads with glaucoma medications in many situations. I come from corneal land, but we do this in refractive surgery, of course. We do have PISC after LASIK. We do have we treat the majority of LASIK patients are myopic patients who are glaucoma suspects, and you can actually end up with a patient who is glaucomatous that you cannot rely very much on their peels because of the peripheral chorioretinal degenerations, and you cannot rely on their applanation. So you have to have fancy eye care machinery to know the exact intraocular pressure. And again, sometimes the disc looks funny. We do now have different things, of course, like the OCTs, but we crossroads with glaucoma in many aspects. The main point, or the main aspect that I'm going to speak about in this short presentation is glaucoma after penetrating keratoplasty, or after keratoplasty in general, endothelial keratoplasty or penetrating keratoplasty. So in corneal refractive surgery, we do crossroads with glaucoma after corneal transplant surgery, or before corneal transplant surgery, after corneal refractive surgery, or before corneal refractive surgery, and of course after phacoemulsification surgery a lot. So the main concern, or the main point that I'm going to speak about, is after corneal transplants. And I think this is a very important concept, because a lot of things, a lot of dilemmas or debates on using anti-glaucoma medications after penetrating keratoplasty or endothelial keratoplasty is there. And there's no like clear consensus. Even in informal chats between renowned corneal surgeons, you find different opinions. So I'll just give you my take on this. And I think I try as much as possible to be like level-headed and not to be a die-hard fan of any one end of the pole. So after penetrating keratoplasty and endothelial keratoplasty, most surgeons prescribe long-term topical steroids. And I'm one of the surgeons that prescribe steroids for only 1 month. If everything is good, after 1 month, I do not continue with heavy steroids like dexamethasone or prednisolone 1%. I go to fluoromethalone immediately, and I preserve my armamentarium of strong steroids if I get any small, mild bout of reaction, not even rejection. But after 1 month, after 4 weeks, I stop the steroids. This is not common among corneal transplant surgeons, because a lot of corneal transplant surgeons keep the patient on heavy steroids for quite some time, and even keep them on 1 drop of dexamethasone for life, and if everything is absolutely fantastic. But in these patients, there is an incidence of post-PK glaucoma. I've seen patients referred to me because they have heard that I'm a corneal surgeon, and they did very nice corneal surgery. They have very nice corneas, totally the graft is taken by the body. Astigmatism is very low, but you take a look at the back side of the eye and you see a white optic nerve because these patients have been put on steroids for quite some time. So because of the incidence of post-penetrating keratoplastic glaucoma, most of us prescribe routine topical anti-glaucoma drops for a long time. I think the second biggest population of using anti-glaucoma medications are post-keratoplasty patients. So this is good. I mean, it is good practice to give your patient prophylactic anti-glaucoma medications from the first day post-operatively when you do a penetrating keratoplasty or even endothelial keratoplasty. But which medication should we prescribe in these patients? I see an overwhelming tendency to prescribe carbonic anhydrase inhibitors with beta blockers combinations like Cosopt, Azarga, Zolamol, and all the very famous eye drops that we all know. Okay, and a lot of doctors, a lot of very good corneal surgeons would put the patient on Cosopt on the very first day post-operatively, and this will remain for a long time, years and years and years. So is this appropriate? Is this safe? And this is the point, one of the very key points that I'm going to speak about today. Carbonic, there's some things in medicine, in ophthalmology and in all medicine that is just in front of your eye and has been there for quite some time, and you actually know it, and you have answered it in exams and written it in exams, and you actually do not use this information in your clinical practice. For example, this is one of the things, carbonic anhydrase inhibitors and the endothelial pump. There has been a controversial literature reports, but classic teaching, as we have been taught that we should not give steroids, for example, in corneal ulcers. There is the skull study that evaluated the role of steroids in corneal ulcers, infective corneal ulcers actually, and changed our minds a little bit when we were taught as residents, and what we teach our residents is never ever give steroids when you have a bare stroma with no epithelium. So the things that we were taught pre-hand is that the carbonic anhydrase enzyme is present in the corneal endothelium. And when we used to study ocular physiology, we knew that it was one of the mechanisms of keeping the cornea clear. And that by inhibiting this enzyme, actually, you can actually, one of the things that will cause in physiology, one of the things that will cause corneal edema is inhibiting the carbonic anhydrase enzyme and cryotherapy and other things as well. So can carbonic anhydrase inhibitors that we put on the surface of the cornea that definitely reaches the endothelium, can it interfere with this mechanism and promote corneal endothelial cell dysfunction and corneal edema? It was reported in the literature, in the archives in 2003. It was reported as early as in the late 90s, because I remember very well a couple of papers that I actually studied when I was sitting my MD exam. This was back in 1999. So there were reports that carbonic anhydrase inhibitors can cause a corneal insult. Okay, so it was published in the archives of ophthalmology in 2003 that application of dorzolamide increased the corneal thickness in patients with cornea catarrhata. Another report in the American Journal of Ophthalmology, this was I think earlier in the year 2000, reported that dorzolamide causes irreversible corneal decompensation in patients with an endothelial compromise. And we have to outline endothelial compromise. In any patient that you're going to do a penetrating keratoplasty for or endothelial keratoplasty for, definitely this patient qualifies for an endothelial compromise. So this is the European Glaucoma Society magazine that's online. And they do a nice thing that every month they give you a tip of the month. In September 2012, and this was not very long ago, this was just 8 years ago, the tip of the month, when the tip editor was Anne Hosta of Belgium. I think Tara, of course, knows her, and she's a very respectable glaucoma specialist. The tip of the month was topical carbonic anhydrase inhibitors can cause damage in the corneas with severe endothelial dysfunction. Again, these patients that you do penetrating keratoplasty, you implant endothelium that has been preserved for quite some time, that has been alive in a patient who died old, and this page and these endothelial cell count, you do expect that there is an annual decrease in the endothelial cell count, and so you are you would cherish each and every cell. Are these patients good for carbonic anhydrase inhibitors, even prophylactically. You're not giving them for any strong therapeutic reason. You're giving them as a prophylaxis. But everyone in Egypt, I see prescriptions from all over the place. They prescribe Zolamol, Azarga, Cosopt immediately after penetrating keratoplasty. In December 2014, there's another sort of informal magazine like the Euro Times and Ophthalmology News and stuff. It's called Glaucoma Today. It's very nice. Because I'm not a glaucoma specialist, I like it very much because it speaks to the minds of the illiterate like myself. So Adam Reynolds of Idaho wrote a review article addressing the topic. And in this article, he said that in patients with endothelial cell dysfunction, the use of topical carbonic anhydrase inhibitors can permanently compromise endothelial dysfunction. In patients with a potential compromise of corneal endothelium, I would recommend considering alternatives to topical carbonic anhydrase inhibitors. Okay. In the journal Investigative Ophthalmology and Visual Sciences in April 2014, there was a counter argument. In a study, a very well done study and very well designed study, carbonic anhydrase inhibitors were found to affect the endothelium of rabbits, but were not found to affect the endothelium of humans. And actually, this was a funny study that it wasn't really an RCT, but the same regimen was given to rabbits and humans, and the endothelial cells were then actually counted, and the corneal thickness was measured in both groups. And then in this specific study, the authors found that the carbonic anhydrase inhibitor did affect the cornea of rabbits, but did not affect that much the cornea of the human subjects that were enrolled in the study. And so they deducted a very strange thing, that the role of carbonic anhydrase enzyme is more profound in bovine corneas than in human corneas. In spite of, I was never convinced for a very simple reason, because most of the ocular physiology that we studied in Adler was not performed was not deducted by experiments on humans. We actually deduced most of our knowledge from bovine studies. So if something happens in the rabbit, this definitely correlates to something that happens in my cornea as a human being. So again, I think this was something with the inclusion criteria. It was just a mere piece of luck that these patients were not affected. So I think the safer bet would say that carbonic anhydrase inhibitor can affect the endothelium, and since it can affect the endothelium in patients or in the subgroup of patients that you are very much aware of the sensitivity of their endothelium, like post-penetrating keratoplasty, we should avoid them or try to avoid them as much as possible. So after penetrating keratoplasty and endothelial keratoplasty, even with controversial reports, even if we hear this from this study and another thing from the other study, I think the safe bet is not to use the carbonic anhydrase inhibitors. These are not the only anti-glaucoma drugs that we have. We have an armamentarium of anti-glaucoma molecules all over the place. So I think we should choose molecules that are not carbonic anhydrase inhibitors, especially early on when the endothelium is just getting well and starting to relive in vivo again in the new patient, especially if long-term administration is planned to avoid steroid-induced glaucoma. So that's that, and that's carbonic anhydrase inhibitor. What about prostaglandin analogs? This is another dilemma and another debate as well. Are they safe after penetrating keratoplasty and endothelial keratoplasty? Since the introduction of prostaglandins for the treatment of glaucoma, we know that they are prostaglandin analogs, and they sort of imitate and they want to be prostaglandin F2 alpha, and their pro-inflammatory effects have been a concern from day one. A number of early studies suggested that latanoprost had a high selective affinity to the FP receptors, so they did not produce that much of a vascular effect like the original prostaglandin F2 alpha. But in 2011, and that's not long ago, Mahdavi et al. In Jules Stein Institute in Los Angeles published a report of 2 patients. This was very, very sort of stunning for me, because this was a report of 2 patients that had immunological graft rejection totally related only to the administration of latanoprost. Okay, this is not a prospective study. This was not even a cohort. This was not even a pilot study, but these are case reports. and it sort of, you know, lightened something in my mind. They concluded that latanoprost can, not must, but can trigger endothelial graft rejection. And this is their presentation. So the pro-inflammatory effects of prostaglandin analogs, latanoprost, have been reported to induce uveitis and recurrence of herpes simplex keratitis all over the years since 1998. There was another publication in ophthalmology itself of a series of 94 patients who developed cystoid macular edema, Irving-Gus phenomena after cataract extraction, uneventful phacoemulsification directly related to latanoprost treatment. 94 patients. Okay, this is in cataract surgery, not in penetrating keratoplasty. But again, this is something that is directly related to latanoprost. In 2017, Macri et al. Published a case report and a literature review on preservative-free latanoprost associated, again, Irving-Gus phenomena after cataract surgery. They concluded that latanoprost cystoid macular edema can occur after uneventful phacoemulsification in patients with no other risk factors. Again, these patients that had ocular surgery, so these are not like normal patients, like open-angle glaucoma patients that you give the primary treatment, or the first line of treatment would be monotherapy with prostaglandin analog. These patients do not have any comorbidity in the form of surgical comorbidity, but it seems that once you open the eye, once you put a knife in the eye, then prostaglandin analogs sometimes are not a very good idea. So this is again the paper. So going back to the mechanism, this is I know this is a bad slide, slide بايخة كده, but this just going back to the mechanism of corneal graft failure. The corneal graft failure, or the pathology or the immunology behind corneal graft failure, allograft rejection is very complicated. But I just take two things: the role of CD4 and the role of CD8. What happens is, we all know that we have the HLA system, and we have the HLA1 system and the HLA2 system, which is the DR system. And the HLA2 system are only found on antigen-presenting cells. We used to think that the main antigenic load and the main antigen-presenting cells were the endothelial cells, but we found that there are other cells. Actually, the endothelium is not that much of an antigen-presenting cell if you compare it to, for example, the Langerhans cells, which are found in the corneal epithelium. So what happens is, when these cells present the HLA2 antigen, the CD4 cells, which are T cells, T lymphocytes, they become activated. And when they become activated, they secrete interleukins-2, they activate other CD4 cells, and they activate B lymphocytes and other type of T cell lymphocytes, like the big sort of tanks, the killer cells, or the CD8 cells. So the CD8 cells again become activated. What they do is they do a very funny thing. They activate other CD8 cells, they secrete interferons, and they actually increase the production of the antigen on the antigen-presenting cells. So why do they do this? They do this to activate or prime macrophages. And once they prime macrophages, the real battle starts, and the real rejection starts, and we see the line of advancing macrophages like the co-deduced line on the backside of the cornea. So why am I saying this? Because for some reason the next slide is not advancing. Okay.
محمد ممكن تحط الفيديو بتاعك عشان احنا وحشتنا.
انا مش عارف ان انا شلته.
انت شلته من الاول، بس انا حاسس ان احنا عايزين نشوفك برضه.
يا بيه ما تشوفش وحش، بس انا مش عارف اعمل ايه على الايباد الحقيقه. Actually I don't know how to advance.
ماشي اوكي.
معلش. Tariq told me that I'm يعني technologically challenged, and I think with the iPad this is very, very true. It is not advancing. So would you like me, what would you like me to do?
No, go ahead. يعني continue يعني.
Man, I'm not going ahead, man. I think this is the problem. Type. I will tell.
How many slides
actually
are left? How many slides can you يعني?
لا, very few.
Can you wrap it up
done.
if you want? Can you wrap up?
Yes. Here I am. Okay. So why did I tell you about the macrophages? I think والله دكتور يحيى يعني there are very important messages in this. يعني bear with me for like the next 5 minutes.
No, it's excellent. يعني.
Why am I saying about all the things about the macrophages? Because tafluprost, the new kid on the block, the one that everyone likes now and everyone is talking about, Saflotan or Taflopro or whatever. In a study done by Hos et al., tafluprost was not found to induce any vascular inflammatory response. And this study was it was in the Graves archives, and it was very interesting because it actually had an in vitro arm and an in vivo arm. And in the in vivo arm, it had a long-term arm and a short-term arm. And in all the in vivo by immunohistochemistry, the corneas were not found to give positive immunohistochemical markers for macrophages. In other words, in plain English, tafluprost does not activate macrophages. And in patients where you put a very foreign sort of tissue in the eye and you keep your fingers crossed and you hope that the immune system will not recognize this tissue, you really need a drug that does not activate the macrophages. This is your worst enemy. Okay, so this was the publication. So the final thing that I'm going to speak about, and I really am looking forward for Tariq's input about this. ROCK inhibitors. At last, we do have a common dream, corneal surgeons and glaucomatologists, because the ROCK kinase inhibitors have been developed over the past, well, it has started in 1995. And it has always been said that this will be the sort of a medical solution that will replace endothelial keratoplasty, because at last we do have things, we do have a medication, a molecule that will actually stimulate the endothelial cells to replicate and even to grow. And if not to replicate and grow, the endothelial cells themselves will be much more healthy when they are when the ROCK kinase enzyme is inhibited. It was introduced in 1995 in Japan by Fasudil, but it never took off in clinical practice. Fasudil was a systemic medications that was given for intracranial hemorrhages and stuff. I don't know, it didn't, because it was not effective or if it has a funny name, but anyway, it never took off. ROCK inhibitors have been found effective in the treatment of corneal endothelial dysfunction in Fuchs dystrophy without endothelial keratoplasty. Refasudil is the new kid on the block, approved in 2014 for treatment of open-angle glaucoma and for ocular hypertension. Netarsudil or Ropressa have been approved in 2017. It is used alone or in combination with latanoprost, the very famous Rocklatan eye drops. It used to be with the CK, and now it is with the K only. So are they the future for post-keratoplastic glaucoma management? Suppressing aqueous production by their alpha-2 adrenergic action. They have direct trabecular meshwork shrinkage, like Tariq has been telling us all around, that it's all in the trabecular meshwork. Dilatation of episcleral vessels, hence increasing outflow. It has a direct effect of corneal endothelial cell regeneration and blockage of apoptosis. It's very promising for both corneal endothelial vitality and intraocular pressure control. So time will tell. I think this is a dream. If I do a penetrating keratoplasty and have one eye drop that will actually improve the corneal endothelium and prevent post-operative glaucoma or steroid glaucoma, I think this will be very good. The last two slides is about ocular surface disease and dry eye disease in glaucoma. This slide only has one message. The message is, if you are using anti-glaucoma medications for quite some time, and these anti-glaucoma treatment, because of the preservatives, will cause some sort of ocular surface disease, inflammation, it does not manifest initially as a dry eye. So you will have a good Schirmer test, a good terbinafine test, and again, you will have, in spite of this, an ocular surface disease. We crossroads with glaucoma drops and the cornea in two famous settings. In OCP patients on topical steroids for a long time, we give them steroids. We start them on protopic, on tacrolimus. We give them Icurvis, cyclosporin, but again, we go back to steroids. Some of them are responders and they need glaucoma treatment, and the rest need proper intraocular control for the success of penetrating keratoplasty. In these patients, we should rely on preservative-free glaucoma medications. The second group of patients are the rejected corneal grafts, where again, they are on steroids for a long time. rejections associated inflammation comprise the ocular surface. And again, some are responders, and a lot of them will need glaucoma medications, which are preservative free. To sum up, my personal, this is not recommendations that are guidelines from the Royal College or even from the American Academy. These are my guidelines for myself. My personal anti-glaucoma routine after keratoplasty is I do not use carbonic anhydrase inhibitors for the first 6 months. I use good old timolol, beta blockers for the first 3 months, or I can use a combination of beta blockers and alpha agonists like Combigan, again for the first 3 months. After the first 3 months, when I'm pretty sure that the graft is okay and it has been taken by the immunological system of the body, I switch to preservative-free tafloprost to preserve the ocular surface after 3 months, or use the tafloprost that has a combination with a beta blocker like the Taflopro Plus. I'm waiting impatiently for ROCK inhibitors to replace my current regimen. So that's it, and that's that. And thank you so much for bearing with this very boring presentation.
Thank you, Mohammed. Very informative. A lot of tips and ideas of how to deal with the commonly used drugs, and it's a very useful tips. I think you did a lot of work to collect all this data. That was very informative. Thank you, Mohammed. I think move.
Mohammed, can you stop sharing your screen?
Mazay,
Hello.
please stop sharing my screen, please, Mr. Host.
Yeah, please. So that I can
Kareem,
share my screen.
Last but not least, we will move to Dr. Mustafa Salah, Research Institute of Ophthalmology. We'll talk about correlation of phakic intraocular lens, ICL in particular, and the glaucoma. Tariq, do you have experience with the ROCK inhibitors?
I've just read the papers. We don't have access to ROCK inhibitors yet in Switzerland. As you have given me the mic, I'll just also comment on what Mohammed said.
I was waiting for your comments, Atari, please.
I just got the opportunity.
No, go ahead.
I love that talk, and I share with Mohammed the concept that I don't know why it escapes too many people about the not to use carbonic anhydrase inhibitors in compromised corneas. It seems to me like it's a simple message, but it escapes a lot of people. I think Mohammed made a fantastic, really good talk about intersection between corneal diseases and glaucoma, and sometimes we dig deep into our trenches and we think of ourselves as cornea people, glaucoma people, when at the end, if we are not even physicians in general that treat the human being, then we are missing a lot. I agree with Mohammed about what he mentioned about the latanoprost. I just suspect that a lot of complications that were happening with the latanoprost are really related to the preservative component. And that's why tafloprost, not because it's a magical molecule, but it's mainly because of lack of preservative molecules associated. It is probably gentler on the cornea. I agree with Mohammed that a simple timolol would do the trick if it drops the pressure. I'm not a very big enthusiast for putting tubes in those cases. Some surgeons would put a tube just before doing a keratoplasty. I try to avoid that. And if I am absolutely cornered and I have to do it, I throw it behind the iris. And my last comment is, Mohammed mentioned Combigan. I'm not a big fan of Combigan because studies have shown that Combigan during the day, it works very effectively, but it's not effective during the night. Both the bimatoprost as well as the timolol, they don't work well, so you're not covering the patient well at night. But it is it's a catch 20 something, and it's never easy. I never envy corneal surgeons when they have to manage a case with high pressure. And I think that all the messages that Mohammed said were pertinent and important, and above all else fundamental. So thank you, Mohammed, for that.
Thank you so much.
Okay, Dr. Mustafa is ready to go.
Good evening, everybody. Can you hear me, Yahya?
Yes.
Can you hear me?
I can hear you.
We can all hear.
Okay. So good evening, everybody. Thank you for keeping with us until now. I'm going to talk about very important subject. That's because in my mind that these patients we are treating with ICLs or implants, they are not really patients, they are actually abnormal patients. So that if we're going to implant something in their eyes, we have to take care and be very accurate in doing every step in putting this implant, in choosing the implant, and we have to follow them very closely to anticipate any problem and diagnose it and treat it. So we know that the phakic posterior chamber intraocular lenses are very commonly used now if we cannot use corneal refractive surgery. The posterior chamber phakic IOLs or anterior chamber IOLs like the Artisan are commonly used. They are safe procedures and may be associated with complications like endothelial cell loss, cataract formation, or post-operative intraocular pressure, which is our talk today. So we know all the indications for these cases. They have to have a stable refraction. Very important in our talk today, they have anterior chamber depth wide more than 3 millimeters, and the angle should be at least grade 3 by gonioscopy. For the Vision ICL family, mode of action, it is placed entirely within the posterior chamber, directly behind the iris and in front of the anterior capsule of the human crystalline lens. When properly positioned, the lens functions as a refractive element very near to the nodal point and gives a very good image formation and optically reduce myopia, hyperopia, and astigmatism. What about the lens? We have to talk about the design of the lens. The single-piece columnar lens, plate haptic design, and anterior lens vaulting, which we'll talk about it very soon. So this is a picture of the older design of the lens without central aqua flow. We can see that it has an optical zone, body, haptics, and foot plates, and there is some full thickness holes in the foot plates and on the body. This very important in a proper orientation of the lens. If we do have this design of the lens, we have to do iridoscopy beforehand or intraoperatively. The iridoscopy should be pre-operatively 1 to 2 weeks prior to surgery. They should be of a good size and should be placed superiorly 90 degrees apart. Because if they are more than 180 degrees, it may be closed by the body of the lens. We have to check the patency of iridoscopy prior to surgery and also at the end of the surgery. Intraoperatively, we can do the iridoscopy by scissors or by a retractor, as we will see in the design. This is the new design of the lens. It's called Evo lens. It has it is intended for myopia, hyperopia, astigmatism, and we can see it has the same design except for has a central aperture, what we call aqua pore, and this is how it looks inside the eye, and also it is present in the toric form. This allows aqueous flow and prevent pupillary block. Many study has been done, and it shows that there is no significant change in intraocular pressure over time were detected after implantation of this type of the lens.
دكتور مصطفى الصوت، فانت اثبت على انك بتتحرك الصوت بيروح وبيرجع.
اوكي كده كويس؟
لا كده مش
this is how it looks.
كده كويس.
Inside the eye, we can see that the lens is situated behind the iris with a good hole, which is the distance between the posterior surface of the lens, the implant lens, and the anterior surface of the lens. The upper picture here, it shows a picture of a UVM, where we can see here, remember this picture because we will compare it later on. This is the ICL. This is the anterior surface of the lens. This is the iris, and it is sulcus, not touching the ciliary body. And this is the angle. It is open, and this is the central anterior chamber, which is a good distance. Which is the best vault? Many studies that the ideal vault should range between 250 and 750
دكتور مصطفى اثبت
microns.
الصوت برضو مش كويس، فممكن انت في وضع معين بيبقى الصوت واضح قوي.
كده كويس؟
بس احنا سامعين، احنا شايفين برضو اللي مكتوب في السلايدز دكتور يحيى، فهيز دوينج
اصل في
فاين.
كومنتس كتيره، في كومنتس بتتكلم عن الصوت، فبس عشان
كده كويس طيب؟
كده
كويس؟
كده كويس قوي.
Okay. Also, there is a study which compared two types of the lens, the standard and the one with the aqua port, and the result was that both there is increase in the intraocular pressure, especially in the first and second day, but surprisingly that the one with the aqua port, it has a higher level of increased intraocular pressure, and maybe this is due to a smaller opening than the iridectomy we do with the laser or at the end of the operation surgically. But the voltage change does not affect later on the intraocular pressure. The typical work up should be very accurate, and we can see that we have a lot of measurements, and every one of them is very important. But especially the assessment of the anterior chamber, because remember that we have a less space to maneuver in a phakic eye. This study was done with the OCT, and it showed just placing the implant inside the eye, it will lead to a progressive narrowing of the anterior chamber angle. We have to keep this in mind. This is a surgical technique steps, so we all know it, and importantly, we have to know that the marks on the foot plate is very important for the orientation, so that the lens is not implanted upside down. Now I'm going to show you a quick video. This is the old type. After doing the main incision and the two paracentesis, we inject viscoelastin, but remember, don't overfill the anterior chamber. We inject the IOL very slowly and let it to unfold. And this is the time when you can see it is properly oriented. You can see here that this is the hole in the leading right foot plate, and we can see here down this. Let the lens unfold slowly in the anterior chamber, then lead the foot plate behind the iris. But after implanting, never inject viscoelastin behind the lens. This is very important. And after doing this, now the lens in place, the pupil is over the lens. We do, this is the old type, we do vector iridectomy. It has to be through and through. We will be sure of that by the release of the pigment, and as we will see now, by the red reflex. And then by the red paracentesis. Now this is, after you finish the operation, you have to look to your patient at the first 1 to 4 hours. So this is the picture you should see, a normal ICL vault, which is about quarter to half or half to 3/4 of the corneal slit beam, and it should be very well centered, especially if you are implanting toric IOL. So what are the factors that predispose the eyes to glaucoma after implantation of this type of lens? We know that eyes with high myopia are at higher risk of steroid-induced ocular hypertension and primary angle glaucoma. Also, eyes with hypermetropia, they have also a narrow anterior chamber, and this may lead to crowding of the angle after insertion of the lens. Also, the design of the ICL with anterior vaulting, this predisposes the eye to pupillary block. The position of the IL in the ciliary sulcus increases the risk of non-pupillary block angle closure and pigment dispersion from friction of the lens or the implant with the back of the iris. Now, is it common to have this type of increased intraocular pressure? Actually, yes, but it used to be higher in the older design of the lens. So it ranges from 0.8 to 26.2%. When it happens, it may happen early or immediately or in the first 24 hours, or it may be late, 1 to 2 months up to years after the operation. So this patient has to be followed for a long time. And the mechanism may be open angle or angle closure. Understanding the mechanism of post-operative raised intraocular pressure is important to plan appropriate treatment and prevent long-term sight-threatening complication of glaucoma. So one of the mechanisms is retained viscoelastic or intraoperative anterior chamber oval film. These eyes usually respond to conservative treatment with oral and topical anti-glaucoma medication. Sometimes it may need longer time to control the intraocular pressure. So the tip here is you have to inject the methyl viscoelastic and don't overfill during the operation, and never to inject behind the ICL after implantation. And you have to thoroughly and gently remove the viscoelastic, either passively with TSS and with a cannula or actively by irrigation aspiration. Also, you can do a slight incisional pressure over irrigation, and this may facilitate evacuation of the viscoelastic. Most importantly, you don't use forcible or extensive irrigation near or into the central hole. This may lead to damaging of the lens capsule, as a paper was published reporting on this. So what other mechanism? We can have a pupillary block mechanism, more common with the new model with the central flow aperture. Why? Because sometimes this may happen in the first day, and this may last for transient time, couple of days. Maybe this is due to central aqua port blocked by the retained viscoelastic behind the ICL. It may occur later in patients because of the axial lens growth, decreasing the vault and pushing the lens forward. So this is a case with retained viscoelastic after the ICL. We can see here that there is edema, and after some time, because this patient came after 2-3 months, there is focal cataract formation, and after 1 week of the follow-up, the aquaflow porch was open, and the cornea was cleared, and the anterior chamber was deepened. The other mechanism is the non-pupillary block mechanism because of the oversized ICL. As we see here, that the oversized ICL with excess vaulting more than 1,000 micron, this led to angle crowding and predisposes to angle closure and increased intraocular pressure. This could be conferred by anterior segment OCT and UBM, which is very important tool to help you in diagnosis. As we see here, there is a crowded angle in this area. So how can we correctly do sizing of the ICL? Either we use the white, which was commonly used by calibers or topography, or sulcus to sulcus, which is done only with UVM, and it has it is operator dependent and maybe variable measurement, and angle to angle by OCT. Actually, we have to combine 1 or 2 or 3 of these methods of measuring to reach the proper size. This is how to use the different types of measuring the white. Also, another mechanism is pigment dispersion with excess trabecular meshwork pigmentation. This was common occurrence following prophylactic laser iridotomy because usually many times this may close and you need to do another session of opening this iridectomy. But also with excess ICL vaulting, constant friction between the posterior iris and the ICL may lead to this type of glaucoma. Also anatomical alteration of the cerebral sulcus because of the annual crystalline lens growth. It is usually managed with anti-glaucoma medication. Sometimes we need ICL explantation. This is how you diagnose it. We can see that here there is pigmentation on the lens and there is increased ongonioscopy, excess trabecular meshwork pigmentation. Actually, there is grading for it from 1 to 4, and you can evaluate exactly the mechanism. Also, another mechanism is malignant glaucoma. It is reported following ICL implantation in both hyperopic and myopic eyes. This is because ciliary body irritation and inflammation for a long time by sulcus ICL could lead to anterior rotation of the ciliary processes, shallowing of the anterior chamber, and aqueous misdirection. We diagnose it by the action of the block and patency of the iridectomy if it is an old type, and also there is no excess ICL vaulting measured by ultrasound on our OCT, and on doing ultrasound scan, you can see vacuoles in the vitreous with no suprachoroidal effusion or hemorrhage. Usually treated by strong psychoplegic, topical anti-inflammatory medication, and aqueous suppressants and hyperosmotic agents. If this was not successful, we should do a pars-plana vitrectomy to evacuate the vacuoles and reduce the pressure. Sometimes some people will try to do formation of the anterior chamber, which is flat both centrally and peripherally by viscoelastic, but actually usually it fails, and this is a clue that this is a malignant glaucoma. This is the case with malignant glaucoma. We can see here that there is fixed dilated iris, although the iridectomy was open, and there is many iris patches. And this case was treated by pars-plana vitrectomy. We can see here that the cornea cleared and the anterior chamber deepened, and the pupil remained mid-dilated after it because of the iris effector ischemia. Also, this is an OCT showing that the vault was all right, and there is here a shallow angle, but the center area and the peripheral, the other angle was widened and returned to normal with decreased intraocular pressure. Another mechanism, although this lens, because of the property of the collamer, it minimizes the inflammation and flare and cellular reaction, and actually it is covered by fibronectin, and the body immunity does not recognize it as a foreign body. This is what leads to this property and decreased inflammation. But it may happen because of either wrong sizing reading, a chronic irritation and inflammation, or something you use, or TAS syndrome, toxic anterior segment syndrome, due to the glove powder or the wrong or bad type of the viscoelastic or the use of pilocarpine. Actually, I had a case like this, and it was presented second day by cloudy cornea, high intraocular pressure, flare, and fixed dilate pupil, and we give her anti-inflammatory and anti-glaucoma, maximum aggregate glaucoma treatment, and actually this patient recovered well within 1 week and remained only with fixed dilated pupil. This is in the literature, we can find there is a recent paper of the same toxic anterior segment syndrome after implantation of phakic ICL. Also, another cause of glaucoma is trauma. We had a patient who had a trauma with a pipe on his eye, and the ICL, which is very rare, although it is very thin, it displaced in the anterior chamber. We can see here that one of the foot plate is above the iris, and so that this was an old type without aqua port, and because of the rotation of the IOL, it blocked the iridectomy and led to ocular hypertension. Also, we may find the ocular hypertension. This patient usually we implant in high myopes who are prone to long retinal detachment, either buckling or partial vitrectomy. So if you have a very tight encircling buckle, this may increase the tension and push the ICL and cause pupillary block. In the literature, I found a case of reverse pupillary block after retinal detachment surgery, and the reverse pupillary block, maybe Dr. Tarek may tell us about it. Instead of you have an anterior iris bombay, you have a posterior iris bombay. This may be alleviated by doing YAG iridotomy. The other and final thing of the causes that you miss pre-existing open-angle glaucoma, and you think that this glaucoma or ocular hypertension developed after implantation. So you have, because the evaluation of glaucoma in myopes is challenging because of the effects and the peripapillary and posterior pole changes, which may lead to visual field defect. So we have to do a very careful preoperative evaluation and do visual field testing before, in case we need it for the follow-up. As this case, which we can see here, that is a very tricky optic disc picture with, this is not a glaucomatous field changes, it is due to the chorioretinal atrophy. So the question comes, if we need to explant, when it's explanted, and can we change or we combine with another types of drainage surgery? So we can expand if we have a refractory glaucoma, or the glaucoma ended up with the cataract and you have to remove it with the cataract, or in severe recurrent inflammation. Actually, I had a case which was a young patient, 16 years old, and he had in my mind that he had a bad sizing of the IOL. He had a recurrent inflammation for a long time, ended up with uveitic glaucoma, and we had to remove the ICL and do subscleral trabeculectomy for this patient. Also, trauma, as we said, you may have a combined cataract with it, or a retinal problem, so that you have to remove the ICL to visualize the posterior segment. Or if you have upside down implantation, which was very common if you are a novice surgeon or you didn't follow the rules to implant it in the right way. Or if you have an oversized implant, you can just exchange the implant and the problem will be resolved. So if the explantation is difficult, actually no, it is really, as we'll see in this video, this is a case which has a cataract, as we see behind. Just do your paracentesis and go with the old incision. And then you inject the viscoelastic in front and behind the ICL, and bring the ICL into anterior chamber by very gentle maneuver. And then once you manage to get the ICL over the iris, inject again viscoelastic, and then grasp the ICL at its long axis as it was injected. We remove it in the same way. Have a good grip because it is slippery, and you can grip it here. And you are not worried about the lens if you are not going to, if you are going to do cataract. So it comes and folds itself in the incision, and that's it. Very important that you check the ICL removed, because sometimes it is cut and some of the so this is another case which was implanted upside down. very short. Because I was afraid of the cataract, I widened the wound. I grasped the ICL, and you can see that there's a lot of pigmentation here. So after this talk, we came to a flow chart to think about raise the IOP after ICL implantation. You have to look to the angle and if it's open or closed. With the closed angle, you have to think if it is a pupillary block or non-pupillary block. If it is non-pupillary block, either you have excessive ICL fold or malignant glaucoma, and then you manage accordingly. If you have a pupillary block, then you check the iridotomy. If there is no iridotomy, if it's the new with aqua port, the aqua port is blocked by the viscoelastic, or the peripheral iridotomy is blocked due it was a small or due to inflammation, and then you can go on and do another YAG capsulotomy or surgical capsulotomy. If it's a patent peripheral iridectomy, it is blocked by the haptic of the ICL, so you have to manage accordingly. If the angle was open, you have to look to the angle again, and if there is excess trabecular mesh pigmentation, this in the long run will lead to secondary pigmentary glaucoma. You have to follow the patient up. If it is a normal trabecular mesh pigmentation, you may have a retained viscoelastic, or you use strong steroid. This is steroid-induced glaucoma, or you missed preoperative juvenile open-angle glaucoma, or you have a dual mechanism. So this is how we think of the post-ICL ocular hypertension. So now I'm going to present a case. This is a female, 20 years old, with high myopia, -16. She had bilateral ICL with aqua port 3 months ago. The intraocular pressure after 3 months was 24 in the right and 25 in the left. And this was on topical maximum anti-glaucoma treatment, 3 types of drops. So I sent her to do UBM, and we can see in this case that the angle was very narrow angle. Nasally, it's almost 8 degrees. The center anterior chamber depth is 1.25 millimeter, very shallow. There is no pupillary block, and there is iris ICL touch temporary and very narrow set. The same picture was in the left eye. So what are the options in such a patient? Shall we do a YAG? We can now put the poll, please. Yes. Shall we do YAG PI or surgical PI, ICL explantation, or eye explantation plus drainage surgery? We will wait for poll results. And also the panelists can share us. I don't see the results of the poll. So the panelists can tell us the result now that 35% choose to do YAG PI, 9% surgical PI, 50% did the ICL explantation, 6% did ICL explantation with drainage subscleral trabeculectomy. So can we take the opinion of the panelists? Unmute yourselves and please share us. Dr. Tara, Dr. Yahya.
What did he do? We want to know what did he do.
What did I explanted the ICL, and this led to the deepening of the angle and deepening of the anterior chamber, and resolved the problem. So I explanted the ICL bilateral and let the patient wear contact lenses.
Makes
So what's your
sense
opinion,
to me.
Dr. Mohammed?
Yes, makes a lot of sense. I was just going to say what Tariq was saying now, but I have just a quick question. Would you? How old was this patient?
20 years.
Oh, okay. Okay. Yes, I would have done the same.
And the reason you explanted is why? Because of the intraocular pressure persistent, or because of the high volt?
Both, because the high pressure was not controlled by 3 types of the drops. It's still high, and she's still young.
One of the tricks, we always, of course, it's very nice presentation. It's very comprehensive of all types that possibly you can get glaucoma from ICL. But one of the tricks that every ICL surgeon should know, we normally, we know that there is a certain percentage of people that there is a problem in sizing. And this sizing problem can either lead to shallow anterior chamber and hence secondary glaucoma, or flat vault, and this can
Cataract.
induce cataract anterior subcapsular. So the trick I want to talk about is the high vault. If you have a high vault, immediately once you follow up the patient, if you follow up the patient next day, in a few days later, and you see you are definite that this is high vault, and you see the angle is shallow, don't wait. The best way is to go in and rotate it to the 90 degrees, because we measure horizontal wide to wide from the sclera, and this is shortened than sulcus to sulcus in the vertical. Actually, the vertical sulcus to sulcus is longer than the horizontal sulcus to sulcus. And consequently, if we have, and we usually implant in the horizontal position because this is what we measure preoperative. So one of the tricks before thinking of explanting an ICL for this reason is just go in from the paracentesis and rotate 90 degrees. And most of the time, this is useful.
Actually, I all my patients, I measure sulcus to sulcus by the OBM with other measures, but actually, most of the time I have no problem. But actually, I have just heard Dr. Awadeni presented a case that he had the same problem, that horizontal implantation ended up with intractable glaucoma, and he was thinking to remove the ICL, but he did what, as you said, he rotated vertically, and this dissolved the problem, and the anterior chamber deepened, and everything went all right then after.
And the most common, in my opinion, the most common cause of increase in intraocular pressure, early increase in intraocular pressure, post ICL, is the use of methyl cellulose. I always recommend using a visco-cohesive. So as you can 100% remove it very easily at the end of the surgery. Most of the patients who get early post-operative rise is related to using viscoelastic, viscodispersive, which usually you don't remove all of it. We all know this from cataract. So one of the tips is use visco-cohesive, not viscoadapt. So
Yahya, I have a comment here that it's not only to use even the active irrigation aspiration. I don't like it because there's sometimes fluctuation of the anterior chamber pushing the lens back to touch the crystalline lens. I do a passive irrigation and they press the wand. This is my favorable technique to remove the ICL. Also, I do many times this very rigorously for as long as it takes, so that before closing the pupil, I am sure 100% that there is no viscoelastic. Also, you can recognize the viscoelastic. Sometimes it's a little bit pigmented. It removes some of the pigments while you injected of the iris, and it goes behind the ICL. If you see these pigments still there, then you are sure that there is some viscoelastic still behind. Also, nowadays I'm just doing one paracentesis to manipulate the lens, and I don't do two paracentesis. But again, use whatever you are suitable with, and at the end you have to have complete removal as much as you can of the viscoelastic.
Okay, thank you, Dr. Mustafa. I think we move, we're about to conclude. Dr. Tariq Sha'rawi will answer some questions from the audience.
Actually, I would like to take some questions from the audience. But before that, I would like to congratulate Mustafa. That was very comprehensive, and we learned a lot from that. And I'm very interested in what you said about the steroid-induced increase in intraocular pressure.
Yes, actually, I have a recommendation here.
Please.
But I can't remove my slides. I don't know why.
Hola, Mustafa.
Well, it is better now not use the strong like prednisolone acetate after the ICL. It is better because this is really a very high risk. This myopic patient, they are very high risk of steroid-induced glaucoma. So I use low potency steroids like FML or fluorescein. So this is better to use it instead of prednisolone acetate.
So my advice on that would be always to be patient and to consider that some people will have an increase in intraocular pressure also because of systemic steroids. So we always have to ask the question. I had two patients who lost vision, one because of a shampoo that was steroid, full of steroids, full of prednisone. And they had another patient who had a significant reduction in or constricted visual field because of an anal ointment for a treatment of anal fissure. So it is always important to ask our patients, are you taking steroids, and really to dig deep, because in some cases you have a patient that is perfectly stable, an operation is perfect, and then something happens and the pressure goes up and goes up very high. It happens more in children and young adults. So and young adults are usually your domain in doing refractive surgery. So not just topical steroids, but any other type of steroids for psoriasis or for whatever. I'm wondering if any of the attendees would like to raise their hands for questions. Do we have anybody that is interested to ask the panel any questions? So far, I'm not finding anybody that is actually raising. There's one person. Yeah, I see Dr. Khalid Al-Ghazali from the UK. Dr. Khalid, I'm promoting you to a panelist. Is that working? Let's see. Yeah, Dr. Khalid, can you share your camera and unmute your mic, please?
Yes, thank you. Thank you, Tar. It was very nice, actually, presentations and covering a lot of topics, which is really important as correlation between cataract and glaucoma. And it's very easy to understand, because it's not in French. Anyway, yes, there's just one comment, actually. I think the first presentation was done by
Dr. Yahya.
Dr. Yahya, yes. One of the things actually she mentioned, and I just about the importance actually of
Dr. Khalid, we can hear you.
Dr. Khalid is muted, so if
Dr. Khalid, can you unmute, please?
Oh yeah, sorry about that. So yeah. Well, yes, one of the things actually which was very important actually for the patient who have this very nice case about the anterior insertion of the zoniole. I had few of these cases actually, but not as much anterior as this one. But yes, you can actually tell sometime when you start the capsular excess that the zoniole is a little bit too anterior, and then you have to make sure that you have a very high magnification when you do this capsular excess to see exactly where the insertion is, and then make sure that you actually stay inside the insertion of the zoniole. And what I usually do at the end of the operation is that I polish the anterior capsule thoroughly to make sure they don't get any phimosis, which can happen with this kind of problem because the capsule is a bit small. And I recently, what I used to do actually, like a 2 small snips in the anterior capsule, very, very small snip with the scissor, the anterior capsule, and leave it like that. I don't increase the capsule or anything, just make that snip. And I feel that sometimes decreases the possibility of the phimosis later on. I don't know what the panel think about that.
Yahya, do you want to take that? Yahya?
دكتور يحيى, unmute yourself يا باشا.
Thank you, Dr. Khalid. I think the idea of if you have complete, as I illustrated, that there's 2 types, essentially 2 main types: complete anterior, long anterior zonule insertion and partial. The more common is the partial one. But if you have the total, like this case, the insertion is so central, actually you cannot work inside it. It would be like 3 millimeters capsular axis. So in retrograde, I would do the same side. The capsular axis with me was fine, but definitely you are tearing the zonules. So I would do is to have segments to suture from the beginning of the surgery, like Ahmed segments to suture it, and to be ready also with capsular hooks. Then this would work fine.
Yeah, absolutely. I agree with you. Yeah. The other point which I want to mention actually is that with the patient, we have a very shallow anterior chamber. I think the important thing, as Dr. Yahya said, that is to actually have some sort of like a good capsular access. Once you get a good capsular access, then you can actually manage everything after that. And once you have the good capsular access, what you can do actually make a small groove in the nucleus, and take a small sector of the nucleus to remove. And then you find that when you do that, you debulk the anterior chamber a little bit, it deepens a little bit, makes the maneuver of the capsule of the nucleus much easier, and you can take bits by bit, and that will make it much easier after that. Well, thank you very much. It's a real presentation, absolutely perfect. Thank you very, very much.
Thank you, Dr. Khalid. I have 2 other questions. I have Dr. Nancy Kamal. Dr. Nancy, if you would like to pose your question, we've been given the microphone. Yes, Dr. Nancy, can you unmute your mic, please? Dr. Nancy, I see that your mic, yeah, here you go, please.
Yes, doctor.
Yes, we can hear you, Dr. Nancy.
Yes, you hear me?
Yeah, we can hear you very well.
Okay. I thank you very, very much. I attend this lecture, and yeah. I gain so much information about ICL explantation. I really attend the lecture from half an hour. Sorry, I have some problems. But I see that ICL is very hard operation. I have learned it so much, but I haven't do it before. But I'm very interested in cataract operation, mainly in pediatrics.
Mustafa, do you want to comment?
Well, the difficulty at the beginning of the learning curve is how to load the lens. But actually, putting the lens in the eye, it's really not difficult for a surgeon who is doing a phacoemulsification. You have to stick to the rules, and then it will be easy. The problem with the ICL that you have to be gentle in your manipulation and you have to follow the patient for a long follow-up. This is, in my opinion, the difficulty. But as a procedure, you can practice the loading with somebody from the company, or you can attend wet labs for this. It's very common now to attend this lab. And then if you have enough experience to work inside the eye, then you will be more than clever to insert the ICL.
I've invited Dr. Wael Manawi to join us. Dr. Wael, we would love to hear your comments.
First of all, thank you very much for your very informative presentations. I have one question to you all about the fourth row pupilloplasty. I know Dr. Tariq has given his diplomatic opinion about it already, but would you consider this as a preparatory for some sort of an angle procedure, like an eye stent or a GAT or something for this patient, and preserving the conjunctiva for a later procedure if you need it?
Honestly, no. I wouldn't. Again, I wouldn't, because I think that you are doing it to open the angle so that you can put something in the angle structures that would later work and drop the pressure. My sincere worry about that is that even if we open it, the problem is not just a morphological problem of looking at the angle and seeing a trabeculum or not. The real problem for me is the fact that the angle, my molecular structures have changed because of the irido trabecular touch over a certain period of time. So I don't see it as an in-between step. I know that some surgeons, Ahmad Assaf gave a talk the other day, and he was mentioning that he would do that in some cases of angle closure glaucoma that are pseudophakic or aphakic to avoid trabeculectomy. And in his hands, he has shown some interesting results. I am very skeptical about doing that. I think it's very traumatic. And as Muhammad has rightfully pointed, you are doing a significant load of work in an eye that is fragile. All those eyes have already a certain degree of endothelial damage by virtue of having angle closure. So, you know, the risk-benefit ratio for me doesn't work. But I would be interested to hear what Muhammad or Yahya or Mustafa would you. I would put the question to you: would you be interested to try something like that, or would you do something like that?
Yes, I would be interested to do. But on the other hand, it's not a load of work, Tariq, to do. And it's not a lot of manipulations. You only actually pass the needle from one point into the iris and going out from the other side, and then you do the fourth rows. So, and usually it's two sutures, one up and one down. So if properly done, I think it's not too much manipulations. But as you said, I'm not sure if it is going to work or not, but I'm interested to try it. But of course, you have more experience of the pathogenesis of the problem.
Yeah, I respect absolutely what you're saying. My training has been that an extra paracentesis means extra loss of endothelial cells. So I'm a very light-handed surgeon. I do not want to play a lot in the antechamber. I treat the antechamber with a lot of loads of respect. Let's put it that way. What about Muhammad? Muhammad, what is your?
I have a very quick comment. If we go back in time and see that these patients had peripheral anterior synetia, so they had inflammation in the anterior chamber, and definitely this inflammation, however subclinical or however minimal it was, it caused a loss of some of the endothelial cells, the cell population, number one, and the cell function, number two. So again, you're starting your operation in a patient that doesn't have that good endothelium. So why do an extra step? Plus the fact we have known that hitting the iris even with a kiss from the phaco tip, you would pay for it in the early post-operative period with flare and cells. We did studies before with the laser flare cell meter back in the day when in the 90s, and we found that the worst lenses and the iris claw lenses, and whenever you touch the iris, you get a sort of reaction, even if it is a subminimal reaction. So you go inside in a patient that had a reaction before and had a bad endothelium, and you're doing an extra step. I totally agree with Tariq that an extra paracentesis is an extra step. So in these patients, I would like to do something that is very sure to keep the pressure down. Although the technique is like a magnet, it's very nice for recording, and it's a very nice challenging technique to do it for the first couple of times, and it brings down the pupil. It has other indications. I do it when I have like a sectorial opening in the pupil, when I have a pupillary defect, in many things. But to do it in order to treat glaucoma, I think this is like shooting a mosquito with a machine gun.
Safa, do you want to add in a few words, because we're going very late now and we still have one more question to take. Mustafa?
Somebody has questions for me, or?
Tariq, base same point.
No, I don't know what's your preparation for such cases before trying to manipulate. I know that we routinely do spectral microscopy before going to any cataract surgery now, phaco especially. But in these such cases, do you have a number, restricting number in the shape and in the count before doing all this manipulation?
Well, none of us has experience with it.
Yeah, I mean, I of course, as Muhammad said, I did the operation many times, but not to reduce pressure. I think we have with us Professor Usama Al-Mahrawi. Usama, we would be happy to hear your comments.
Assalamu alaikum. It's a pleasure to see you all and learn from you, and thanks for Orchidia. I would like to ask Dr. Tariq Sharawi if you can give us some comments and more highlights about steroid responsiveness, because this is important. Steroid responsiveness, about the incidence of that response, severity of that response, factors that affect it. Is it genetic or something like that, please?
So thank you for your question. And in very briefly, steroid response can happen every time you use steroids by any means. You know, if you are taking nasal inhalation, if you are using a cream, etc., etc., and obviously for eye use, for you know, for preparations for the eye. The best advice that I can give you is always look for what we call the super responders: high myopes, people with primary open-angle glaucoma, patients who are relatives of primary open-angle glaucoma, and finally children. Those are always super responders. Those are the people that you have to concentrate on measuring the pressure in you know, well spaced, to make sure that you are not missing steroid responses. Of course, the big curse in Egypt and in many places in the region has been, you know, allergic conjunctivitis and the terrible abuse of steroids. And I unfortunately had to go into the misery of having to operate a lot of patients that would come after losing one eye, and you operate the other eye just to save it with already you know, a concentric visual field. So find super responders, look very well, and when the pressure is high, stop the steroids and be patient, because it can take weeks. So don't jump into your surgical scrubs and surgical hat and go into the operating theater. Wait. I mean, even if it takes weeks, I had children that I overloaded them with Diamox or Sidamex just to pass this period of not having to actually you know, take them to the operating theater. Traumatic cases of angle recession. We usually see those patients, we give them steroids, and then the pressure goes up, and we think that it is going up because of angle recession. Angle recession takes usually months to years to happen. So stop the steroids and wait. I think I hope I answered the question the best of my ability. I would like to take some closing remarks from Yahya, Mustafa, and Muhammad. You guys have been awesome. This is probably, this is my last webinar for the season. I'm out. Enough. I've done enough. I'm tired. But this has been my favorite. I really enjoyed the interaction, and I enjoyed learning so much from you. Out of the last 20 webinars that I've done in the span of 4 weeks, this one is my definite favorite. So, Yahya, some closing remarks, and I would also ask Muhammad and Mustafa to do the same.
Thank you, Tariq, for the idea of the webinar. Thank you for the idea of putting our pictures when we were old. We definitely all learn, and it's always nice just to discuss and to give the other opinions, even if we don't agree. This is better because the audience will always hear something, and they will always see some strange people playing with sunglasses at night. So thank you, Tariq. Thank you, Mustafa. Thank you, Muhammad. Really, it was, there was variation and information, and you are breaking the law, Tariq.
I'm doing it at my home. Muhammad actually put his glasses like his photo. I unfortunately can't grow a mustache in 5 minutes, but that only tells you that the four of us go a long way together. We've known each other since we were literally kids, and it's an absolute pleasure to spend this time with you and spend the time with the participants. I'd like to ask to thank RM for the impeccable support that we have been given over the last couple of months. I also would like to thank Orchidia for sponsoring that. The collaboration between Baladi and Eye Care and Dar Al Ayun and other big establishments in Egypt has been always fruitful. Baladi Foundation rests on your shoulders, guys. We always abuse your time, and we thank you very much for the great role that you are doing and all the gift of time that you and skill that you're offering to people in south of Egypt. I think with that, I would like to conclude this fantastic webinar. This is, for me, has been a time very well spent. Thank you very much. And thank all our participants. Thank you.
Thank you. Thank you.
Bye.
مع السلامة.